Just wanted to say to the organizers, we were all at PCF last week, and they had a joke off. And I don't know if you know it, but Walt Stadler's a sleeper. He's like a really good joke teller, and I imagine Oliver, with all the time you spent in hunting lodges, would probably be a good joke teller too. So you might want to consider working that into the meeting. All right. Well, my assigned topic was biologic rationale for targeting the AR in the future. And just to set the stage, everyone in the room here knows that this is what we have now to work off of in terms of therapeutics. And all of these treatments are approved for pretty late stage disease, metastatic castration-resistant prostate cancer. And I think one of our challenges will be to figure out how to move these therapies earlier in the disease where we can hopefully impact cure rather than just prolonging. So to think about the future, we need to really understand the receptor and the pathway. And this is just a cartoon, and I'm not going to go into it in detail because everybody in this room is intimately aware of all this. But I would like to say that in the 24 years that I've been working in this area, our understanding is just increases, every year by so much, and that increased knowledge allows us to apply drug development in these areas where we never thought possible before. And I would just say, for instance, look at in the last year with Emmanuel's coming on the scene with ARV7 and the other ARVs, how much investigation has gone on. It's really, truly tremendous. And at the end of the talk, when we segue through some data that we have on abiraterone resistance, I'll show you some of the drugs that are currently either preclinical or just getting into the clinical arena. And they really do take advantage of some of these areas in the AR pathway that the current drugs are just starting to target. So in terms of abiraterone resistance, we've done some work in this area, and as Scott just went through genomically, it does appear that the AR transcriptional activity is restored, at least in a substantial fraction of ABI-resistant prostate cancer patients. So I do believe it continues to be a target, perhaps not in all patients, but if better inhibitors are developed, this could still be a player, at least a co-player. Many of the same mechanisms that are involved in progression of primary prostate cancer continue to come up in these secondary arena of resistance. And I'll show you data that we have for residual steroids as well as AR mutation. And there's also a lot of changes in co-pathways, particularly the multi-kinase pathways. So we've recently completed a study that we started a while ago, adding dutasteride to abiraterone, and it's a phase 2 study, so we're really not comparing it to anything, but we do have patients have metastasis biopsies at baseline and progression. So we have a nice cohort of 40 paired biopsies, and this is some IHC of androgen receptor at baseline in relapse from a patient on this trial. And the androgen receptor is fully there in force. And we do see that in the majority of patients, although sometimes it's certainly heterogeneous. And this is to say that the androgen receptor not only is there, but it appears to be activated based on serine phosphorylation. And the middle two series of slides there are 2 patients who are on the abidutasteride slides in their metastasis biopsies. These are from bone at baseline and progression, and especially the second one there, which has more bulky tumor in it. You can see that the androgen receptor remains nicely phosphorylated. These were done by a pathologist, Wei Wei Yi, and Steve Bock's lab. This is a paper we published a few months ago from patients from the same abidutasteride cohort, as well as one patient from our neoadjuvant study. And this is looking at sequencing of the androgen receptor. And out of 17 cases, 3 of them had the 878 mutation which we, I believe, were the first to publish many years ago in the context of back then just flutamide resistance. But this is an androgen receptor mutation that's activated by progesterone. And as you know, progesterone is a ligand that's upregulated in the context of abiraterone treatment. So it makes a lot of sense that this would be an escape mechanism for some of these tumors. This here is in situ looking at ARV7, and we haven't published this yet, but this is from one of our neoadjuvant abiraterone cases. And it's two areas from the same tumor, one of which has high full-length AR expression and fairly high ARV7 expression. This is a prostate now, prostatectomy tumor after 6 months of abiraterone treatment. And another area in the same tumor has low full-length AR and low ARV7. So I think we have a lot to learn in this area. You know, the variants are there in normal prostate as well as early prostate cancer and late prostate cancer, and there's a lot of interaction with full-length AR, and I think we're just starting to understand the complexities of this and how it will impact our therapy as a biomarker and possibly as a treatment target. Switching from the receptor to the ligand, again, I think most of you in the audience are very aware of this, but there is a lot of areas along this pathway where the tumors can sort of bob and weave and change their synthesis or metabolism, catabolism of these enzymes and the subsequent ligands that they produced. So we know from work from Pete Nelson, Steve Bach, and others that there's increased de novo androgen synthesis. So whatever receptor you have, which is generally reduced, at least at first in castration therapy, can be tackled by increased ligand. Then there are changes which increase the export or catabolism of CYP17 antagonists, like the abiraterone and other drugs itself. And I have a slide coming up from work that we've done with Nima Sharifi, which is under review, which looks at this area and is really quite fascinating. And then, there's the whole story, and I'll show you some data that we have, that some of these ligands in the middle part of the pathway, particularly DHEAS, seems to be favorably held onto by these tumors or produced, and may be an area that we can target. So this is some work that we did from our neoadjuvant abiraterone trial. These are serum hormones. We have tissue androgens too. And it did appear in this work that the DHEAS and the glucuronidase remain relatively increased compared to the others. And then here's the tissue. And I don't know if I have a pointer here. But if you look, this is 12 weeks and this is 24 weeks. So after 3 more months of abiraterone, these levels are starting to trend up in the tissue. And obviously it's hard real time in the clinic and to patients, but I don't think we ever really know enough about what's going on in the tissue, especially over time when patients are on these therapies for more than a couple months. And this is really nice work that Elahe Mostagal is submitting for publication soon. This is from the neoadjuvant trial. And the black bar are the patients who had very good pathologic responses, either a complete pathologic response or less than 5 millimeters or tumor. And those patients appeared to have the more favorable transporters, and they also had higher abiraterone levels in their tissue. And by way of saying that if we have drugs like abiraterone that can get to their target and stay there and do their job better than our first generation, we may make a much better impact in this disease, especially early. This is just to introduce Nima's work because it's not published yet. I didn't want to put the data up, but Abiraterone is metabolized to D4A, which turns out it's actually a more active and potent metabolite than abiraterone itself. And then it's either 5-alpha or 5-beta reduced to 3 separate compounds in each of these areas. And it turns out that those metabolites are actually agonists to the androgen receptor, to the tumor. And if you can block the 5-alpha reduction, like we did in our trial with dutasteride, you actually can keep the level of D4A higher and therefore keep the antagonistic activity against the tumor higher. So this is also a point in the pathway that we may be able to work better at, maybe better drugs than dutasteride, for example. So I'm not going to talk too much about enzalutamide resistance because we didn't have any primary data that was ready to share, but Andy Armstrong gave a nice talk at PCF about snail, which is a mesenchymal protein, which may be involved in resistance. And I think there's a talk coming up later in terms of increase in PD-L1 expression in the context of enzalutamide resistance and possibility of co-targeting that pathway. And in addition, there have been AR mutations, particularly the 876 mutation, which is seen with enzalutamide as well as others. So it's the same players in different proportions that come along in the resistance to these drugs. I wasn't sure how much Scott was going to show you about the stand-up to cancer work, but I wanted to focus on the androgen receptor changes that we did publish in Cell, and he had so much data in there that this was buried in there, so I think it nicely segues with Scott's talk. So there were 5 or 6 centers in our DREAM team, and it's been a really fruitful experience, especially for a clinician like myself, because the patients have these biopsies, the tumor gets sequenced, and then we do all meet together and we have these precision medicine tumor boards where in prostate and other diseases at the Farber we'll discuss the results and do an exhaustive search looking for something unique for these patients. And one of my patients just turned out, it was like perfect for Scott's talk. It has a MSH2 mutation, and he's currently having another tumor biopsy because the trial requires it, but he's going on a checkpoint inhibitor trial in the phase 1 group in the Farber. So I think it's early days, but I really do think that this type of program, maybe a little boutique-y now, but is starting to give patients other benefits. So in terms of what we have in this paper here, the patients, the lymph nodes, 43 of them were bone. And I was just saying to Nick Vogelsang, it was back in the 1990s where in CLGB we did the first bone biopsy, metastasis biopsy in prostate cancer project. We did 200 metastasis biopsies from bone in the context of, believe it or not, an anti-androgen withdrawal trial. And so it really is a little bit back to the future, but because of how much prostate cancer is in bone, it's an important avenue to explore. And Scott just showed you this, but this is the landscape of the mutations that we saw, and you can see the androgen receptor right up there under P53 in terms of the mutations. And then the next slide goes a little more in detail in terms of what we saw. And about a third of them had these androgen receptor point mutations. All of them, most of them actually, described previously. The 702 one there is the one that's stimulated by hydrocortisone, and we use steroids with abiraterone, so that may be impactful here. And then I'm not going to talk too much about splice variants because Emmanuel's talking later and others that can update you more, but I did want to show you just in terms of normal prostate, localized prostate cancer from the TCGA, and the stand-up to cancer, the AR isoforms that are seen here and the proportion that they are seen in. So to get to the point of the talk, what is our next generation of AR-directed therapies? And these are some of the compounds that are in testing now. Some of them are just starting out in phase 1, and then others like ARN-509 and galetirone are actually in phase 3. So ARN-509 is a lot like enzalutamide. It does have reports of increased potency and decreased CNS penetration. ODM-201 is also a AR antagonist. It also has some activity against CYP17. EPI-001 is the N-terminal androgen receptor antagonist, and this will be the first in class. And I think a lot of us are excited to see how well that does, especially in the context of the splice variants, that drug's from Miriam Sarter. Galetirone is a compound that has triple mechanism of action, AR antagonist, CYP17, and also is an AR degrader through the proteasome. And that is the first biomarker-directed trial, phase 3. It's an industry trial run by Tokai, and patients will be selected for ARV7 and randomized to galetirone or enzalutamide. BT464 is a CYP17 inhibitor. It's more selective than abiraterone, has decreased hydroxylase activity, and reportedly has some androgen receptor antagonistic activity. Bromodomain inhibitors are, I think, an exciting class of molecules that are also in the clinic. And a few things that are maybe more experimental or in preclinical or very early clinical stage of development. One is metformin, and until I started thinking about it recently, I was never really sure what the issue with metformin was on the androgen receptor, but it turns out, look at that little light blue circle there. Midline 1 is a protein that complexes and is involved in androgen receptor translation and post-translational events. And it turns out that's where metformin works. It blocks the translation of androgen receptor. So that may be a compound that we can work into our treatment paradigms. I doubt it will work particularly well by itself, but maybe in combination with other inhibitors along the pathway. This compound here, nicolosamide, is an antihelminthic, and it actually degrades ARV7. There's also one or two androgen receptor DNA binding domain inhibitors, which I think are also pretty cool, and I hope those come along quickly for our patients. There are other androgen receptor degraders, heat shock protein inhibitors, and working on the ligand aspect of the pathway, AKR1C3 inhibitors. Indomethacin is one that's pretty dirty, but there's others that are likely to come along. So I think it's really exciting. Like, I think, wow, like, you know, how many years do we just use flutamide and bicalutamide? And now there's this explosion of not only compounds, but compounds that work very differently on this important pathway. And I think there's a lot of potential for combining them either together or with co-pathway targeting, which I decided not to talk too much about because I think that's a topic unto itself. Okay, this is my attempt at being funny, and most of you who know me well know I'm not really that funny. We are Back to the Future. October 21st, a couple days ago, was, you know, the Back to the Future day. And you know, I started doing this 24 years ago when we were pouring sequencing gels through glass plates and sequencing part of the androgen receptor at a time. And now look what Scott showed us and how much is able to be done in such a short period, and, you know, hopefully it'll become more affordable. So there are challenges. We know that. We haven't cured prostate cancer yet, especially advanced prostate cancer. So we need to figure out how to overcome iterative resistance. It's going to happen. And, you know, we just need to keep focusing on that. We need predictive biomarkers. We need to be smarter about our treatment. I think Oliver, in his introduction, went through that. You know, we're starting to make headway. The AR variants. Chuck and others have nice work on serum. hormones as prognostic and predictive markers. And then there's a whole exciting area of circulating tumor DNA and CTC profiling. We need to develop effective intra-AR pathway and co-pathway targeting. And then I really think, we need to get smarter about using these drugs earlier, for big response, what I call big response or cure. And then we can't lose our sight on managing the long-term side effects, because none of this is easy for the patients. Thank you. I'll stop there and happy to take questions.
Mary Ellen, I think you're very funny. Always have. Any questions from the crowd? If not, I will ask one. John? Okay.
Yeah, just a really question, because it looks like a fair amount you put in there, like the metabolism of the drugs and everything, that could be a really pretty rapid way where drugs could either become more effective, and then you bring in the bromine, bromodomain inhibitors. So do you think epigenetic approaches, we do know in some others with the signal transduction inhibitors that potentially some epigenetic approaches might, prolong activity or enhance activity. Do you think this is the same thing? Should we be looking epigenetically to try to prevent, the protection mechanisms when you're inhibiting the androgen pathway?
Absolutely, absolutely. I think we haven't even begun to look at changes that can be co-targeted, methylation, HSP90 inhibitors, a lot of opportunity there. Thank you for mentioning that.
Oliver?
Yeah, so Mary Ellen, the work from Manuel has shown that the taxanes seem to be pretty effective when the V7 is present, you can eradicate some of those V7 clones, and or V7 CTCs would be the better way to say it. And we've kind of danced around this topic for years. Why aren't we putting together the taxanes and the novel hormones now? It almost seems like we've thought about it for so long that we've almost forgotten to think about it.
I think it's going to be happening. Yeah.
Yeah, I think there are some trials with abiraterone and enzalutamide and chemotherapy that are ongoing. I don't have any data to share, but
there is a trial. We're doing a trial through the PCTC of abiraterone versus abiraterone cabazitaxel, and it's an RB-driven protocol. So there's a biomarker built in with it. So that's going on. So it's around halfway through.
Hey, Mary Ellen, a quick question. So several years ago, Pete Nelson's group did a study where they took individuals who did not have prostate cancer, and they put them on medical castration therapy, and then they did prostate biopsies, I believe it was, and showed that the prostate gland actually was this sort of sink of androgens, and that as the androgens in the serum went down, the concentrations in the prostate went up. And first of all, I'm wondering if there's a similar relationship in your neoadjuvant studies, or do all the serum androgens just basically go to zero once you start giving abiraterone? And two is, do you think that that's a physiologic mechanism that may actually come back and sort of harm us in the end, in terms of you had the prolongation of the abiraterone therapy where the DHEAS starts to creep up a little bit. I thought that was very intriguing.
Yeah. I do think that the prostate has mechanisms to, just keep changing to increase their androgen concentrations in the prostate, no matter what the serum levels are. I think there's, this constant interplay between what's in the serum going in, but we've seen in all our neoadjuvant studies that, especially the ones we've been able to sample the prostate over time, that they're, I think what happens very quickly is everything goes down very quickly at the beginning, and then there's this slow trend up as the drugs lose their efficacy and the enzymes are changing in terms of, developing resistance around the therapy. And I think it happens really quickly.
Yeah.
Like, I think I have this bias in the charted setting, the metastatic hormone sensitive setting. Nobody's really done good work in this area, but I really think the biggest bang comes when you start everything all at once. you know, and when we used to use estromustine, some of the best responses seem to be when you like plow down the hormone pathway with the MSIT, you know, together with Lupron and chemotherapy. And I think in the hormone sensitive setting, that would be a really important question to sort of
We've
look
just
at.
changed our Dream Team protocol where we're going to start biopsying patients pre-ADT, pre-docetaxel who have de novo metastatic disease to try to get to that question. So it'll be interesting.
Great, thank you.
All right, thanks.